Our next speaker will be Dr. Paul Lane. He was born in England, but for the most part grew up in Utah. He did undergraduate work at the University of Utah and went to medical school at the Medical College of Wisconsin in Milwaukee. He did his residency at the University of Missouri in Kansas City in emergency medicine. Then he came back to Utah, where he's worked at McKay Hospital since 1993, and he's the former emergency department chief. He will speak to us on the emergency department's narcotic policy. Dr. Lane.
It's good to be here with you this morning. When Dr. Hylison talked to me about giving this presentation last year, I envisioned a small group, maybe 30 or 40 people in an intimate setting. Last week when I inquired as to how many there might be here, I was told it was going to be around 350, so I almost called in sick this morning. But the topic I'd like to address is an important topic and one that impacts the emergency department quite a bit. And the goals that I'd like to obtain with you this morning is first to give an overview of some of the statistics both on a local level and on a national level regarding the abuse and misuse of narcotics, and then take the last half of the presentation to explain what we've done at McKay in our emergency department as far as our narcotics policy goes. What we were seeing over the last decade was a marked increase in the number of visits from people that were on chronic pain management with narcotics. And we found that this increase started about 10 years ago and correlates very well with a push by the Joint Commission and by some federal and state agencies to improve pain management. But the initial push was really more in four categories. It was dealing with people that had terminal illnesses, people that had malignancies, post-operative pain, and AIDS-related pain. But since that time, that push has really spilled into other areas, some of which have little support in the literature as far as efficacy and the long-term safety goes. And we were finding that we were having to deal more and more with some of these issues in the emergency department in areas that we were not experts in dealing with, and in some cases somewhat uncomfortable in trying to address the chronic pain and some of the abuse and misuse that went along with this. So as I said, I'd like to present a few of the statistics both on a local and a national level. In 1991, there were 32 deaths as a result of non-illicit drug overdoses. Over the next next 16 years, that increased to 317 deaths. Now, the number is actually probably higher than this because these numbers only deal with isolated non-illicit drug overdoses. Those that are mixed overdoses are not included in this category. And most of these are from prescription opiates. I think we tend to think of those that abuse drugs as being in a younger age group, which is true. This is a problem that is indeed in the younger age group, but those that are dying from this tend to be a little bit older, with a median age of 40 and a rate that's higher for those that are obese. If you look at this graph, again, you can see that there is an increase in the slope that begins about a decade ago, and this again correlates very well with this push for better pain management. Historically, when you look at unintentional injury deaths, the number one cause of that has been motor vehicle accidents. Over the last few years, prescription medication overdoses have surpassed that. They listed statistically in the category of unintentional injury deaths, and these do not include suicides. If you look at the distribution of some of these drugs, both in Utah and in the United States, now I recognize that these statistics are a little on the old side, but I think this trend has continued to increase since 2002. But these are legally distributed drugs, and you can see that in all categories, in these three categories, that the use has increased, and in all categories that Utah tends to be above the national levels. Unfortunately, many of you have read, as reported in the Standard Examiner, about a sad case of one of our colleagues to the north of us who is, I believe, going to trial next month over a 4-year period of time. His physician wrote prescriptions for 20,000 prescriptions for hydrocodone, which amounted to 1.9 million pills, and 17,000 prescriptions for oxycodone, 1.5 million pills. So about 3.5 million pills, almost 1 million pills a year, just from one physician. And naturally, this problem tends to spill over into the emergency department. More on a national level, an 8-year period here, you can see that all of these drugs, all of these narcotics increased significantly, particularly the methadone. And methadone statistically accounts for a disproportionate number of deaths from narcotic abuse and misuse. You'll notice that codeine is not on this list, and codeine was the only one that actually decreased during this period of time. And during the same period of time, the use of illicit drugs remained fairly stable or even decreased, with one exception, and that's marijuana. Marijuana still surpasses the use of narcotics. Between 2002 and 2007, more prescriptions for hydrocodone with acetaminophen were written in the United States than any other medication. Now, there's a mistake on this slide. The category should not be in there. It's just than any other medication. The number 2 drug was Lipitor, and number 3 was amoxicillin. And in the United States, even though we only comprise 40% of the world's population, we consume 80% of the opiates and 99% of hydrocodone. In the United States in 2009, you can see that the abuse of narcotics significantly affects the emergency department. 1.2 million visits were due to the abuse or misuse of pharmaceuticals, and about 400,000 of those were due to narcotic pain relievers. The admission rate, again, these are numbers that are a little bit on the old side, but I'm sure the trend has continued, but a significant rate in the admission for treatment of narcotic pain medicine addiction. I found this statistic to be very interesting. In 2005, 60% of the non-medical prescription drug abusers were obtaining their drugs free from friends and family. I think we tend to think of people that abuse narcotics as maybe going out and meeting their drug dealer somewhere and picking up their medication. But the reality is that these drugs are obtained from people that they know that are likely getting them through legitimate sources, and they're getting them free. So that leads us to the policy that we've put in place. So I'd like to go over what our policy is and why we put it in place. I think some of the statistics that I've gone through kind of explain that to a certain extent, and the results that we've seen because of our policy, and then some of the challenges that we still face with it. So I hope this shows up okay. I'm just going to read through this and then we'll kind of explain parts of it. Due to the increasing problems of narcotic dependency and accidental overdose, both locally and nationally, all the physicians of McCady Hospital's emergency department have established the following practice for those who suffer from chronic or recurrent pain. This practice applies to those who seek medical care in the emergency department 6 or more times in a 1-year period, or 2 or more times in a 4-week period, for chronic or recurrent pain conditions such as migraine headaches, tooth pain, back or other musculoskeletal pain, or recurrent kidney stone pain. This will also apply to those who receive regular prescriptions for narcotic pain relievers from their primary care providers. If you suffer from frequent migraine headaches, back pain, or other musculoskeletal pain, toothaches, kidney stone pain, or other recurrent conditions, your condition will be evaluated and non-narcotic pain medications will be offered to you. These may include Toradol, Compazine, Haldol, Imitrex, Vistaril, Reglan, Benadryl, Phenergan, or others. Examples of medications that will not be provided in these instances include codeine, hydrocodone, oxycodone, morphine, Dilaudid, Stadol, Nubain, and fentanyl. If you are receiving regular prescriptions for narcotic pain medication from your primary care provider or clinic and have lost your prescription, had your prescription stolen, or have run out early, we will not be able to supply pain reliever with a new prescription or narcotic pain medication. Other non-narcotic pain relievers will be offered. A treatment plan for breakthrough pain should be worked out between you and your pain medication or pain medicine provider. This plan should seldom include an emergency department visit for narcotics. Thank you for your understanding. When I was preparing this talk, I was hoping to be able to give you some great statistics about how narcotic policies have worked across the United States in emergency departments, but unfortunately there really is no statistics, and literature searches on this have not produced anything that I can find. Now, we put this into place a few years back, and at the time we had some information from a few other emergency departments that were using similar policies, and we looked at their policies, and these were obtained through blogs that our department chief had been involved with. And there's 2 parts basically to this policy. One is to address those people that frequently use the emergency department as a source of treatment for their chronic pain problems, requesting narcotics. And the other part is to address those that are currently on pain medication on a regular basis. And it's kind of interesting to see that if you look up the Doppel report on people that are getting their chronic pain medicine, it seems that their visits to the emergency department often correlate to a time several days before their prescription is due to be renewed. So why did we put this in place? Beyond the statistics that I've just cited, we felt that we needed some objective parameters that we could go to and say, if you've been to the emergency department on a certain number of visits over a certain period of time, then we're not going to be able to provide further narcotics for you. The second reason is that we found that it's been very helpful to actually have something written down in black and white that we can give patients that they can look at and they can read and see that they do truly fall into those parameters that we have established. The third reason is to establish some consistency amongst the physicians, and there is, like many practices, some variation in the physician's level of comfort with distributing narcotics for various problems. And really the fourth reason listed here is probably the most important of the reasons, is that if you line up the physicians in the emergency department and go from those that enjoy, well, I shouldn't say enjoy, but those that are willing to confront patients to those that aren't, you're going to see quite a variety. And there's some, I won't say I enjoy the confrontation. I certainly am willing to confront patients about my concerns about their narcotic abuse. There are others that are less comfortable with this. So when you have a policy that's written up and that they can show the patient, you can basically say, blame the policy, don't be mad at me, my hands are tied in this situation. Unfortunately, when we put this into place a few years ago, we didn't really track statistics on some of our most frequent visitors, but with the assistance of some of my colleagues, I went back and looked up the numbers on 17 of the patients that I could remember and that my colleagues could remember as being some of our most frequent visitors for pain management problems. And I think you can probably quite clearly see from the statistics here when we put our narcotics policy in place, and it was around the beginning of 2008. And prior to that, we'd had the average visits per year in this group was above 13, and the last few years it's been down around 5 visits a year. There still are some challenges associated with the use of our policy. One, we really have not found a good way to flag those that have received a copy of the policy and those that would fall into that category. And so it really requires the individual research by the physicians in the group. And if you're not aware of the DOPL website, I would encourage you to get on to this. It's the Controlled Substance Database that's done by the DOPL, and this lists the controlled substances that have been provided to patients. Unfortunately, it does tend to be a few weeks behind, but nonetheless is a great database. And as of 2007, Utah was only one of 3 states that provided this kind of information. Since that time, I think there's been more that have come online, and there has been a push for a national database, but unfortunately that's not been funded by Congress, so it's not available at this time. And the other area that, of course, the physicians need to look at is to review the records of the patients that have been in. And at our facility, we have the advantage of being able to see all of the IHC emergency department visits as well as the clinic visits, and which is, again, an invaluable resource. But if they see emergency departments or clinics outside of our system, then those records are not available. And on a busy day, going into some of this research is somewhat time-consuming. The other challenge we face is how to deal with situations of physician non-compliance with the policy. And we, as a group, have decided not to have this go through some type of formal QA or review, but rather do it more on an informal basis. The third challenge, complaints, and interestingly enough, you'd think that a policy like this may be increasing complaints, but we've actually found that it's decreased the complaints that we get regarding patient treatment, with one exception. When patients come in and they get a mixed message, in other words, they come one day and receive narcotics and then come another visit and they're told that they can't have narcotics, then they tend to complain more about it. But when there's consistency amongst the physicians and they see that we have a policy and that we're complying with the policy, then the complaints actually have gone down. And the fourth area that's a challenge, which actually has improved, I think, since we sent out this policy, is educating the primary care providers in the community. When we put this policy together, we sent a copy out to all the primary care providers along with a letter of explanation. And I think we found that the community physicians have responded to this and educated their patients. I mean, we would often see people that would come in and have a plan with their primary care provider that they may receive 2 narcotic shots a month for their migraine headaches, and they're in the emergency department on the 2nd of the month requesting their 2nd shot for the month. And these kind of problems, I think, have decreased markedly since we put this policy in place. So that completes my presentation. If this is an area that you have interest, I would encourage you to look particularly at the 3rd reference that I've listed there. This came out a few years back in Pain Physician in 2007. It's a National Drug Control Policy and Prescription Abuse, Facts and Fallacies, and it provides some excellent information. If you have any questions, I'd be glad to take them. I think if your questions are regarding the abuse of narcotics in Utah, I know Randy Lithgow from the Narcotics Strike Force is giving a presentation tomorrow, and he's probably one that would be better addressing those issues, but I'm certainly glad to answer any questions about our experience with our narcotic policy. So.
I guess on a related note, with Joint Commission, we now have the pain as the 5th vital sign. Patients are being asked how they treat pain in the hospital, and these literature is being published nationally. Do you think that move from sort of the government side of things is affecting what you're seeing at the level of EPR, where patients are becoming the big issues and being assessed with their pain?
Yeah, Dr. Ivester was asking about, the push and the pain scales, 5th vital sign, which is not really a vital sign, that we've been encouraged to use, and by Joint Commission, whether that's affected what we're seeing, and absolutely. The problem, as shown in some of these graphs, both in Utah and nationally, has increased significantly in the last decade since this push was put in place, and that's one of the reasons that we initiated this policy, is because of that increase that we were seeing. Yeah, absolutely. That's an invaluable tool, and they've recently updated it so it's much more user-friendly than it used to be. So.
The data you presented was on prescription medications. However, in the emergency departments, you can give medications for narcotics and not have to worry about them taking the narcotic at home. So do you see a correlation between medication given for pain in the emergency department and prescriptions given to be taken home for narcotics?
Prescriptions provided by the emergency physician. Statistically, I don't know that I have an answer for that, but yes and no. For instance, migraine headaches, generally when they were treated with narcotics, which we've gone away from for the most part, it would be a one-time shot generally, and then they would go home. Other issues, again, it's somewhat physician variable. Back pain, for instance, that kind of thing. With chronic problems, sometimes it would be just a one-time shot, but often prescriptions would be sent home with the patient. Randy Lithgow probably would be able to answer that better for you. My understanding is that they all participate, but I can't tell you that for sure. Okay.
Just a comment on that.
Okay.
They don't get their methadone through the pharmacy. So that's one kind of missing link in the system.
And the increase in Mark mentions methadone, the increase in methadone deaths has actually been more correlated with the increase of methadone use in the treatment of chronic pain as opposed to the treatment of narcotic abuse. So. When we put this in place, we weren't really seeing much in the way of tramadol abuse, but certainly over the last few years, I've seen more and more patients that appear to have an addiction problem with tramadol, and it's kind of a difficult one to address because it doesn't come through on the DOPL the database. It's more something that you have to look at yourself. Okay. Yeah, that's a good point. And if you didn't hear that, when you search on the DOPL website, you don't have to put in their whole name. You can use only the first few letters, and that decreases the chance of error on spellings and things. So.
They also suggest don't use date of birth. If you put the date of birth in, sometimes you change the date of birth, you just put the person to come up, and when you go through it, you end up being the same person. One thing I've noticed using it though, a lot of them don't change their street address, but they'll change the city address.
Right. Thank you.
Thank you, Dr. Lane. Our speakers are staying right in there this morning. That is great. They're staying in the slot, and it's nice to have a little time for questions. Dr. Sundwall. Thank you, Dr. Sundwall. That's David Sundwall. Dr. Sundwall is our former director of the Utah State Department of Health and a good friend of mine, and I'm glad to see him at our meeting here this morning.